Welcome everyone. This session is ready to begin. This session is sponsored by Peterson Center on Healthcare. Thank you to the Peterson Center on Healthcare. Tanya Bernstein from Friedman Healthcare will moderate this session. Tanya, the floor is yours.
Thank you, Norm. Hi, everyone. I'm Tanya Bernstein. As Norm said, I'm a principal consultant at Friedman Healthcare, and I'll be moderating today's session on integrating data sets to provide more comprehensive information. I want to thank everyone for sticking with us through the virtual conference format. I know it hasn't always been easy, and the conference over the last 2 weeks, of course. Of course, we wish we were together in person, but I guess this is the next best thing. We think that the integration of various data sets, including APCDs, is a very timely and hopefully relevant topic to many of the people that are attending from the various states today. We do have some great speakers for you that will share the work that they've been doing, including collecting patient-reported outcome measures, linking hospital data to APCDs and also Medicare data obtained through the ResDAC program, imputing race and ethnicity, which we know is very hard to get through claims databases from other data sources, and developing the necessary data governance to enable the sharing from the outset. I'm hopeful we can have a robust discussion and learn a lot from each other. Please submit any questions you have through the Q&A button below. We'll have time for questions following each presentation, and then we'll also have about 10 minutes at the end of all of the panelists. As Norm said, thank you to our session sponsor, the Peterson Center on Healthcare. So with that, I want to introduce our first presenters, and they are Jessie Tenenbaum. Jessie is a Chief Data Officer for the North Carolina Department of Health and Human Services, and Amy Hawn Nelson, who's a research faculty and the Director of Training and Technical Assistance for Actionable Intelligence for Social Policy, or ACE. So with that, I will turn it over to our first presenter.
Thank you so much, Tanya. How's my audio? All right? Yes? Okay.
Sounds fine. Sounds fine.
Okay, good. Hi, everyone. Thank you so much. Thanks to the organizers for allowing Amy and me to present our work today. And Amy's got our slides, so I'm waiting for the first one.
Okay, it says I was sharing. Let me try again.
Okay. There we go.
Does that work?
Yes.
Excellent.
All right, next slide. Okay, so as mentioned, I'm Chief Data Officer for North Carolina's Department of Health and Human Services. This is the second largest agency or department in the state. It's led by Dr. Mandy Cohen. Employs lots of people. This is sort of the background, and a budget of approximately $20 billion. Next slide. So I didn't know that much about health and human services before I came to the organization. My background is more in academia and in biomedical data science, biomedical informatics. There's 30 different divisions. We touch everything from health and human services, so Medicaid and mental health services and services for the deaf and blind and early childhood and public health. And then there's also administrative, dealing with the legislature and procurement and HR and IT and all different divisions. Next slide.
Sorry.
So the services, as I mentioned, are all over the map. Medicaid is certainly the largest division. It's responsible for the biggest part of the budget. We also cover foster care, prenatal programs, child development, and early education. So my twins were actually preemies, and so they had early intervention things. So they're in our databases somewhere. SNAP, food stamps that go by different names. Regulation of healthcare facilities, regulation of restaurants for that matter, regulation of well water, so we do well water testing. Obviously in the COVID era, we do a lot of public health in that respect. Next slide. So these three priorities were, I have to say, pre-COVID. So there's, as I mentioned, we do things all across the board, but to prioritize, the three priorities prior to COVID were Medicaid transformation, which we have finally gotten the green light from the legislature to do, early childhood, and then combating the opioid crisis. Next slide. Okay, so My office, the data office, was created just over a year ago. And prior to that, Health and Human Services provided these services and collected data as sort of a byproduct of the services. But it was recognized over time that data is important, data are important, and that they wanted to create an infrastructure that was really going to leverage data as a strategic business asset, not just as a byproduct. So they created the data office, created the position of Chief Data Officer, and there's 4 components to what we are working to achieve across DHHS. These are these horizontals here. So data infrastructure, just what is the sort of IT infrastructure that's going to enable us to democratize data access? Data governance, what are the processes in place that we want to be able to give people access to data appropriately? Data quality, let's make sure that we know the level of quality. Data are big and data are noisy, and there are always going to be issues, but we want to understand what those issues are, where the data are fit for use, where the quality is sufficiently high to make certain conclusions, and where it wouldn't be something we would want to use for drawing a specific conclusion. And then data use, getting people to start thinking in terms of, we have these data assets, how can people use them and leverage them to inform their work, to make better decisions, and to decide on policy? The verticals here are the different pillars in DHHS that I mentioned. So the Medicaid, Healthy Opportunities is some really exciting work we've been doing around social determinants of health, and then the other areas I mentioned across DHHS. Next one. So this was a slide put together by the new director of the data office, and does a really nice job explaining kind of the direction, the aspirational direction. We're going up the stairs. We are aiming to get to that top right area of predictive models and really understanding, predicting what's going to happen and having that inform our actions. That's the kind of cool, sexy part of data modeling and data use. In order to do that, it really is a staircase this way, where if you don't have those bottom stairs, everything falls apart. And the bottom stairs exist, but not as sort of formally and well understood as we would like them. So we've really been focusing on the bottom part right now, understanding data quality issues, data pipelines, integration. As mentioned, we have all these different divisions, and we handle Medicaid and we handle food stamps. But if you wanted to compare the people who are enrolled in Medicaid and the people who are enrolled in food stamps, finding that merge should not be difficult, and yet it has been, just because the data live in their different silos. So we're really trying to integrate data, build infrastructure that's going to enable us to leverage it across the different divisions and really form an understanding of the people of North Carolina, what their needs are and how to best serve them. Next slide. I think that's over to you, Amy.
All right. So a little bit about our kind of relationship and partnership, Jessie and I. So I work for a group called AISP, Actionable Intelligence for Social Policy. We're a very small initiative out of the University of Pennsylvania. And our main role is to provide support and technical assistance for mainly government agencies, some nonprofits, but mainly government agencies who are trying to figure out cross-sector data sharing. So we do, like I said, a lot of technical assistance. And so I was brought on board to help this, support this process with our little tiny corner of the world expertise. So the big question is, like, why do it, right? So as you can imagine, in this world, it's very hard to get a bunch of division directors in a room and get them really excited about things. But, everyone was very excited about the creation of the data office and Jessie coming on board as Chief Data Officer. And so here are our main reasons why this work is painful and just laborious, right? Like, it is so hard, but we have to do it, right? And so these are our main value propositions for why we have to figure out data access and use and create a standard process for this. So, of course, number one is benefiting North Carolina residents, right? That's what DHHS does. North Carolina Department of Health and Human Service, that's why they exist, to serve North Carolina residents, which, funny enough, I am a North Carolina resident. I work remotely for Penn, always have, even pre-COVID. So I actually live in North Carolina. Mitigating risk. So I don't know if any of you know anything about this, but I describe it as like data is typically either kind of padlocked or it is wide open. And it is usually one or the other, because it's really hard to do otherwise, right? It's really hard to carefully control access. So both approaches have really different consequences, right? Those, I would argue, really open data can be an ethical risk, and really padlocked data is also a risk because you're not using data as a strategic asset. So figuring that out, mitigate those risks. And the next thing is just supporting staff, right? We know, I don't know if anyone else has like data access PTSD. Probably everyone on this call does. Like, we've all begged for data, we've all pleaded for data. We've all like promised things we shouldn't promise for data. But data access is a total pain point, but we have to figure it out because operational needs for data require data access and use. And so here we are, we're trying to figure it all out. I don't know why I have such issues advancing the slides. That is the wrong way. Slide deck, wrong way. There we go. Okay. So here was our process for this work. So summer of 2019, Jessie was brought on board as Chief Data Officer. I was brought on board to support some of the work that she was doing. This is back when she had an office of like 1 or 2. I was like, you know, I don't know what you would call me, like auxiliary. Then we've been very active. She's been very busy staffing the data office. So actually there's now an office and we have like team meetings. It's great. There's people to do work. But during all that process, I was kind of on another parallel channel doing a lot of data collection. So I did a lot of my experience is mixed methods. So a lot of qualitative data collection that's mixed with, you know, administrative data records. So I drew heavy on my qualitative experience, and we ended up doing a pretty hilarious landscape interview. I thought at the beginning I could do it in like 15, 20 interviews. I think that ballooned to over 50 and I just stopped counting at that point. So 50 in-depth interviews on data access and use across the enterprise, you know, across the entire department. And then from there, we went forth and tried to figure out, okay, now we have all this interest, you know, we have all this information, we know how it works, we kind of know how the sausage is made, so to speak, and so how can we streamline it, make it better, use what's working, and then kind of let go or transition those parts that aren't seamless. And I, as you can probably imagine, there are a couple of those. And then COVID happened, you know, so here we are trying to do a lot of this really hard relationship work remotely. So, you know, we're a little off track, but that's all right. We're still making it, as we all are. And so we are continuing this iterative process of designing a guidebook right now. That's our main thing that we're working on, is this guidebook for how to guide data access and use. So just a quick note about what we do at AISP. We support data, you know, cross-sector data sharing. So we don't hold data ourselves. We don't recommend vendors. We're not focused on academic research. We are very committed applied researchers. The academic work we do is very applied work. And we focus heavily on ethical data use and on things that already work. And some might call us, we occasionally call ourselves data evangelists. So using data as a strategic asset. All right, so here is just an overview of this data landscape document, and here are the main kind of action items on what to do. So out of this data landscape came these, we should do this. So this is what the work we have been trudging along slowly and getting to. This is the main product that we're working on at the moment. It is a guidebook is what we're calling it. So it's kind of choose your own adventure. It's not a process manual. It's not like you will do things this way. It's saying in an ideal world, these are the different routes for data access and use, and this is the general way that we'd like you to, you know, go forth and do it in this way. So these are some of the things we're working on, and we hope to have more to present in a future session. Here's a good example of the way that we approach this. So one of the first things we did was we cataloged all the open data assets, so all the data that is currently open. We were pretty broad in our definition, so we included everything, you know, the obvious ones like dashboards, extracts of data, but we also included reports that have lots of aggregated data that you could pull down and scrape if that was your thing. And then now we're working on restricted data, so data that can be shared with data agreements in place, and then also just trying to get a real good picture on the unavailable data. We have really interesting, I'll use that word interesting, laws and statutes around data use in North Carolina, and so just trying to get a handle on those and then make it really clear on when people ask us for data, this is why we can't give that data. We're not, you know, trying to be obstructionist or difficult, but we literally can't because of law or rule or statute. And I think that is where we wanted to end up. So more to come. Whenever we do get this guidebook finalized, which hopefully will be in the next couple months, it'll all be public, and we hope that you will, you know, spend a little bit of time on Google and look at our processes and procedures. We will have an internal version and an external facing place. So the external facing one will be out there in the world at some point. So thank you so much.
Thank you, Amy, and thank you, Jessie. We did get one question, so if others have any other questions, please submit them. But the question that came in is that, Amy, you described a staff CDO or staffing the data office. What roles and FTEs comprise the staff, and what external support do you subcontract?
Jessie, yeah, I'll let Jessie take that.
Yeah,
and then I can add to it based on what we see in other places.
Yeah, so we had initially had a whole org chart, lots of people. We budget things, we weren't able to fill that. But what we have right now is one data steward, hope to get more, one data analyst, hope to get some more, one data office director in place, and then we are soon going to be making an offer to a data policy governance specialist who's going to work closely with Amy. We also, and this is something that has been new to me, but through the state, there's a lot of work with contractors. So a lot of the listing and work that we need done are done by people that are affiliated through these contracts and working on specific projects.
Great.
Good question.
Thank you. Thank you, guys. Let's move on. So our next presenters are from the Pacific Business Group on Health. We have Rachel Brodie. She's a Senior Director of Measurement and Accountability and leads the Patient-Reported Outcome Measurement pilots, and Emma Hu, Director, who focuses on care redesign, measurement, and payment reform initiatives.
Okay, thank you. This is Rachel. Can you hear me and see my screen?
Yes, yes.
Awesome. Okay, good. Then we'll pursue. Okay, so let's see. All right, so Pacific Business Group on Health, or PBGH, is a nonprofit coalition of approximately 40 member organizations that include private employers and public agencies. So we represent some of the largest purchasers in the United States. Our strategies, we collaborate with payers, providers, and consumers to advance care redesign, value-based payment, and policies that advance performance, transparency, and accountability. So this next screen just shows some of our member organizations. And then, so representing purchasers, PBGH is investing a lot of resources in a national initiative to enable widespread adoption of patient-reported outcome measures, because purchasers want to see more movement towards outcome-based measures and believe that the patient is the ultimate source of information regarding whether a treatment or a procedure is successful. Patient-reported outcome measures also bring value to other stakeholders as well. They provide important information about a patient's health and preferences that would not otherwise be available through clinician-reported or third-party data sources like claims and health records. We can use outcomes reported directly by patients and their caregivers to promote a patient-centered approach to care management and help drive quality measurement towards improvement in areas that are most meaningful for patients. This is also data and measurement that can help clinical teams deliver more personalized care and develop effective treatment plans. And generally just helps us assess the effectiveness of given treatments and whether those treatments have resulted in the intended outcomes like improved function or reduced pain. So just a few definitions here that before we continue. A patient-reported outcome, or PRO, is a report about a patient's health or functional status that comes directly from the patient without interpretation by a clinician. So in this example, the PRO would be depression. A PROM, so patient-reported outcomes are typically captured through a patient survey or PROM, which can assess a variety of factors. So in this example, the PROM is the PHQ-9 for assessing depression. And then a PRO-PM is a performance measure. So it takes this to the next level where we are looking at aggregated scores for an entity, whether it be a practice or a hospital or a provider organization, and looking at the distribution of the scores or comparing those scores to an expected target. So in this example, it would be the percentage of patients with a diagnosis of major depression with an initial score greater than 9, that have showed remission after 6 months. So a little more information. In this PROMS strategy that we have 3 core strategies to achieve nationwide adoption of PROMS. We're designing market-based implementations that will demonstrate that PROMS can be collected comprehensively, permitting assessment of virtually all providers for certain health conditions, and I'll show you an example in a minute. We're also aiming to create momentum through education and recruiting key stakeholders to support these implementations. And then finally, encouraging adoption by promoting aligned payment policies and recognition methods. So one example of an implementation and using integrated data sets. One of our projects is a collaboration with the Michigan Oncology Quality Consortium, or MOXIE, which represents 90% of the medical oncology practices in the state of Michigan. They've had a long-standing quality improvement program and also pay-for-performance program with Blue Cross Blue Shield of Michigan. They are collecting PROs for health-related quality of life, pain, and fatigue for patients that have breast cancer, lung, and colon cancer. So to facilitate this PROM collection, they are using Varian's NUNA project, which centralizes and streamlines the PROMS data collection. Automating this process and reducing the burden for staff is particularly important for these Michigan practices that are generally small community practices with just 2 to 5 medical oncologists. So the clinic staff can use NUNA to register the patients, enter basic demographic and clinical information, and then hand a tablet to the patients when they're in the waiting room to complete the survey. And the survey gets automatically uploaded into the system and linked to the patient identifiers and other data. These PRO survey responses are also available for real-time view for clinical decision-making during the next office visit, during that office visit. And then what MOXIE is ideally planning to implement in the next phase is an HL7 integration, which would pull data from the EHRs into the NUNA system so that all of the clinical data is combined and linked with the demographic data and PROMS data in a very seamless and automated and standardized process. So in addition to this adoption, PROMS adoption and use that we're doing in Michigan, we leverage this to obtain funding from CMS to develop and test PRO-PMs. So we're testing these measures with the practices in Michigan and also with 8 comprehensive cancer centers in 6 other states that are part of the Alliance for Dedicated Cancer Centers. So this allows us to do this PROMS work in small community practices and also the academic medical center settings. The ADCC sites have implemented different approaches to collecting the patient-reported data. These are larger institutions that have more IT resources than the community practices for sure. Some of the sites have programmed the surveys into their EHRs, and then they can use the surveys, issue the surveys via email or through their patient portals. And they can also give the patient a tablet in the waiting room in a similar fashion. And then the data is automatically stored in the EHR, viewable by the provider, and easily exported to a third party. A few of the sites are using REDCap, which stands for Research Electronic Data Capture. It's a web-based application for building and managing online surveys and databases. So similar to the EHR implementation, the sites can manually trigger surveys to be sent to the patient via email. When the patient completes the survey, it's automatically stored in the REDCap system and once again, easily exported. But an advantage to REDCap is that it doesn't require the patient to log in to the patient portal to complete the survey. So it does remove one barrier. For institutions that are collecting the prompts through their patient portal, on the other hand, though, they do need to log in, and this could be reducing response rates. So we do think the REDCap it's a very promising solution for doing standardized clinical data collection, therefore easing the data abstraction burden and also collecting the prompts. So I'm going to turn it over to Emma to talk about the next few slides.
Great, thanks, Rachel. As Rachel described in the definitions of pros and proms and pro-PM, using depression as an example, we also have an initiative in California to try to advance adoption of depression outcomes reporting. Many of the organized medical groups and practices currently screen for depression as part of the routine care, but we don't really have a standardized reporting mechanism to benchmark or to evaluate outcomes and depression remission as a measure. As part of a broad initiative working with the Integrated Healthcare Association, we collaborated to identify some common ACO measures that was endorsed by 20 provider organizations representing multiple health delivery systems, purchasers, and 5 national and California-based health plans. And in that process, what we sought to do was identify measures that were meaningful to stakeholders, but also tried to move the needle in representing outcomes as opposed to traditional claims-based measures that, from a data perspective, we've all gotten accustomed to based on many of the HEDIS measures that are currently part of accreditation and performance measurement. At the end of the day, our goal was to advance depression measurement because of a key priority of improving mental health care and improving identification and access to mental health services across the state, but also to look at how we could use this enterprise to change the platform for measuring outcomes from a patient perspective and looking at how we could report this data on a consistent basis across multiple organizations and multiple sites of delivery. We have also had interactions with folks in Massachusetts, which have currently integrated depression screening as part of a measurement in their alternative quality contracts under Blue Cross Blue Shield of Massachusetts, as well as MassHealth has been looking at deploying this more broadly in the Medicaid environment. The next slide. As I mentioned, working with the Integrated Healthcare Association, we have been trying to move the needle on the types of measures in use. And on the left-hand side are some of the mental health measures that are currently deployed at the medical group level. And our goal at the end of the day is to advance standardized adoption and reporting of these measures, and specifically looking at depression remission at 6 months as an outcome measure. The next slide. But as many of you are aware, there are tremendous data challenges in capturing patient-reported outcomes, and Rachel described some of the different mechanisms that we currently use in capturing the oncology measures. Historically, we know that many organizations have implemented the PHQ-9 and the PHQ-2 screening questions as a way of identifying individuals with potential high-risk needs with other multiple chronic conditions as comorbidities. They also have used the PHQ-9 as a general screening for those organizations that have expanded their primary care medical home capabilities or have integrated behavioral health and primary care as part of an advanced primary care model. But, you know, as many of you are aware, you know, the process for collecting this data is hugely varied. And in a pre-COVID environment, it was very common to have people sit in the waiting room and fill out these surveys often on paper, in some cases on tablets, and that environment has completely changed. One of the major challenges with respect to capturing PROMS data is how to build it into the workflows and to make it easy for both providers and patients, and also to make the data available for use in the patient care visit. Historically, sometimes as we saw patients filling out these surveys in the waiting room, the information would be immediately available for use in the visit, but the information may not ever make it into the electronic medical record because it required subsequent data input by office staff. We also, have seen adoption of improved technological capabilities that involved push messaging apps and EMR portals that require patients to log in prior to the visit to fill out the surveys. But, as Rachel noted, when a additional login is required, that often diminishes the response rate. We also, have seen a lot of different types of platforms on which such data is captured, and our challenge has been how to integrate these at a patient-specific level into a system that ultimately can support performance reporting. What we have found in a lot of the organized medical groups is that the case management staff or other disease management registries are commonly in use as vehicles to identify individuals that may benefit from repeat screenings, and also as triggers for follow-up for individuals that are part of case management programs. But oftentimes these systems reside in the organized medical group infrastructure and are not necessarily connected in real time with the office-based EMR or provided to the physician at the time of the office visit. So, in thinking about the different methods, we're, evaluating approaches that can optimize the workflows and identifying collaborative learnings that can help us prioritize the best practices that groups have identified and communicate those to other groups that are earlier in their stage of adoption. Going to the next slide, as Rachel noted, some of the key requirements are multi-fold from a provider engagement perspective. It's critical that the information be actionable so that the data is meaningful from a provider engagement perspective and is useful in the office visit setting. The PHQ-9 is a great example insofar as it provides structured responses that result in a score that provides information that then is actionable from the perspective of identifying individuals that may be in need of interventions to address depression, or who might be borderline and trending up or down, as well as identifying specific risks like suicidality. As one of the key issues is the process for scoring that data be quick enough that it's useful in that office visit environment and also can be well integrated into the workflow. With respect to some of the opportunities for improving the integration with providers, having the alerts and triggers for follow-up surveys, as well as integration with the EMR, are key elements for improving experience. At the same time, in thinking about how the information is used, having the capabilities to trend results over time and visualizing the data is also helpful to identify individuals who are improving versus individuals who might be at greater risk. And ultimately, that visualization can provide feedback to physicians with respect to benchmarking performance and identifying pathways for quality improvement. And then ultimately, providing that data on an aggregate basis for performance measurement and accountability uses. The next slide. similarly, from a patient engagement perspective, having the information reinforced during the provider visit and using that information as part of the messaging to provide feedback is also important for engaging individuals, as well as in many cases, PROMs can be used for treatment decision support, as well as self-monitoring to measure outcomes and improvement over time. And at the end of the day, we can also see utility in providing reminders for individuals to reinforce self-care goals. And by integrating that data, it provides a more comprehensive picture both to the patient and the provider. So in conclusion, moving to the next slide, some of the key opportunities are, as we diversify the sources of information, integration of those third-party solutions and apps with EMRs, as well as real-time data exchange, are critical elements to making PROMs a reality as part of the provider office visit and intake process, as well as making it seamless, regardless of whether the visit is via telehealth or in person. Over time, we're seeing greater opportunities to standardize the data sets and also to integrate PROMs in value-based payment and accountability, initially through some of the CMS P4P programs, as well as the commercial programs and bundle payment initiatives. So with that, I'll wrap up and, we can address questions, at the end of the session.
Thank you so much. That was very interesting. Yes, if you have questions, please submit them and then we'll get to them at the end. Hopefully we'll have time. So next I'd like to introduce Dr. Zhang and Kat Nwachukwu from the Center for Health Information and Analysis in Massachusetts, also known as CHIA. Dr. Zhang is the Senior Director of Research and Kat is the Assistant Manager of Research.
Hello, could folks hear us?
Yes.
Oh, great. Well, thank you, Tanya, and good afternoon, everyone. Thank you for having us today to share our experience in linking data from state and federal sources, really to advance our analytic and the research agenda. Next. As some of you may know, the Massachusetts Center for Health Information Analysis, or we call it a CHAIR, is an independent state agency that reports on many things, access, utilization, quality, affordability, outcome of the Massachusetts healthcare system. Our data and the reporting has been used by a variety of stakeholders, including our sister agencies, policymakers, payers and providers, employers, researchers, and the general public. Over the past couple of years, CHAIR has undertaken a phased data linkage project, which Kat, my co-presenter, will describe more next. We did experience some delay in implementation, particularly for the last phase of the linkage to bringing ResDAC data due to obvious reasons, COVID-19. So for our presentation today, we will have Kat share some of the background information and introduce our linkage project. I will then share some of the details of our linkage methodology and to talk a little bit about our plans to use the linked data sets for various analysis and research projects. Without further ado, let me just hand off to Kat.
Thank you, Z. So as you mentioned, I'll be talking you through a little bit of background about the CHIA's linkage project. So state and local health data organizations have widely used state-specific hospital discharge records and available claims data to analyze and report on health system performance. In Massachusetts, we use discharge records from a variety of acute care settings, including inpatient, emergency department, and observation. We use these to measure key performance measures like hospital readmissions and revisits. However, we know that discharge records are limited when it comes to payer type and revenue information. So payer type on discharge records is the expected payer source, so there is some potential for miscoding. Additionally, when analyzing payer type information from discharge records, a decision must be made on if and how to account for primary and secondary data source payer sources listed on the record. And though we collect revenue codes and charge amounts on discharge records, this information may be unreliable or incomplete, as it's not the data source that hospitals use for payment. And lastly, patient enrollment information, including number of months enrolled or transitions from one insurance carrier to another, can be limited or even completely absent from discharge records. So the limitations of payer type on discharge records is further highlighted when we consider how records belonging to the same patient are identified. Typically, we use social security number to link discharge records to one another, and so that's within inpatient data and across other discharge sources like emergency department and observation. However, social security number is increasingly missing from acute care hospital data, and this varies greatly by expected payer source. So whereas patients with Medicare have under 5% of records with missing or invalid SSN, commercial records have 15% missing SSN. So this greatly limits our ability to fairly link patient records within our discharge databases. However, despite increasingly missing SSN in our case mix or acute care hospital data, we have explored linking discharge records to ResDAC Medicare data using social security number. And when we looked at the match rates between our case mix data and ResDAC Medicare data, we only found 82% of case mix records with the primary payer type of Medicare in the ResDAC data. Based on what we've seen in other studies, we would expect this match rate to be much higher, around 95%. Furthermore, almost 60% of patients aged 65 and over in the case mix data who did not indicate Medicare as their primary payer type were found in the ResDAC data, which we'd expect to be much lower. So both of these issues point to potential miscoding of payer in the case mix data and the limitations of only using social security number to link patient records across data sources. To address these challenges, CHIA has undertaken a 3-phase linkage process that leverages both Massachusetts-specific and federally available data to ultimately enhance our case mix data. Phase 1, which involved linking patients within the Massachusetts case mix databases, was completed last summer. And in phase 1, we created an algorithm-based unique patient identifier that enabled us to link discharge records between and within the inpatient, emergency and observation databases. Phase 2, which is almost complete, linking the to the claims database. APCD contains enrollment and claims for most insurance carriers, except for and this linkage enhance our identification of both the mass health and commercial in our discharge data. And in phase 3, the focus of today's presentation is the combined case mix APCD data from phase to Medicare beneficiary data from ResDAC. Phase 3 will help us better identify Medicare fee-for-service beneficiaries and those who are dually eligible for Medicare and Medicaid. As I mentioned, phase 1 create case mix only patient identifier. This was successfully used in an analysis of statewide unplanned all-payer readmissions. The patient identifier greatly increased our capacity to keep otherwise valid and complete discharge records despite high rates of missing SSN. This was especially apparent by payer type, where both the Medicaid and commercial populations saw significant increases in the number of eligible discharges and readmissions we were able to include in our analysis. I will now pass it back to Z to discuss the methodology and next steps for phase 3 of the linkage project.
Thank you, Kat, for a nice introduction to our linkage project. I just want to also mention that Kat presented a wonderful use case from really linked products from phase 1. And she did that wonderful presentation last week as part of the NADO presentation, and folks can look for that. So our phase 3 linkage goal is really to link ResDAC with case mix and the APCD databases across time. The final linked database with all 3 sources will greatly enhance the coverage of the entire population in Massachusetts, particularly the Medicare fee-for-service population, as Kat mentioned earlier. So they're about 80% of the Medicare beneficiaries in Massachusetts, and they're not really well captured in the Massachusetts APCD. So we use IBM Master Data Management, or MDM platform for the linkage. I'll get to the linkage fields a bit later. Let me just talk a little bit about the steps. First, we'll begin with the linked APCD case mix file from phase 2, as Kat described earlier. We will then develop a new scoring matrix by adapting our phase 2 linkage algorithm. Our goal is to satisfy all 3 data sources requirements for linking individuals. And finally, we will refine and implement the new algorithm to bring ResDAC data into the mix, and then to match patients or members across all 3 databases. Next. So here are some of the really details of linking fields from each data source. As you can see, case mix has the most, including social security number, date of birth, gender, zip code, patient names, and then detailed addresses. We also have a relatively new field, health plan ID, taken from membership card as provided by the hospitals. APCD has similar fields to case mix, with the exception of detailed addresses. And some of the common fields from ResDAC include social security number, date of birth, gender, zip code, and Medicare beneficiary ID. Next. To implement the linkage, we will first match patients or members deterministically within each data source. So for case mix, we mainly rely on organization ID, or ID for hospital, and the medical record number. And so for APCD, we mainly rely on organization ID, or ID for a health plan or carrier, and the carrier-specific member ID. And for ResDAC, we use Medicare beneficiary ID. Next. The second step of the linkage would be a probabilistic linkage process. As I mentioned before, we would adapt the matching rules that we used for phase 2 linkage, linking case mix and APCD. Here are some of the examples. Let's take a look at perhaps scenario number 1. We could all agree that there shouldn't be any disagreement here, right? So scenarios 2 through 6 are essentially thresholds we developed from phase 2 to determine a match. For example, in scenario number 6, if a social security number, date of birth, I guess Kat has some internet connection issues, and I wonder, so I'm going to continue to talk and see if Kat could bring that slides up. So the slide that you saw last was really different scenario on the threshold that we developed. Oh, thank you, Kat. You're great. Determine a match. And we also, Kat, could you advance to the next one? Wonderful. We also learned a lot from phase 2 linkage that will inform our development, implementation, and improvements of our phase 3 linkage. For example, you know, in scenario 1, if first names are different, date of birth is missing or not, really, and all other fields match, that could be a situation where, you know, you have same gender twins given mom's social security number, whether or not date of birth is missing. If we take a look at the number 5, if the first last names are different or other fields match, that could be 2 different names, same town, same gender, same date of birth, but social security number somehow got transposed. We really have some technical challenges here, but I'm going to continue. So hopefully I'll finish up very soon. Kat, could you advance to the next one? Thank you. I know you've been having internet connection issues, but great, it's back on. So evaluating the success of linkage is an important part of the process. Here are some of the examples we plan to do to assess the quality of linkage, borrowing again experience from earlier phases. So for matched records, we would like to evaluate the concordances of demographic variables and the pair characteristics between case mix and ResDAC. Similarly, we were looking to non-matched records to assess distributions of demographic and pair characteristics from each source. We would also explore any potential data issues for any subgroups that have low linkage rates. So these analyses would be instrumental in providing feedback to improve the linkage algorithm and also to increase reliability of our linkage process. Next. As we wrap up the second phase of our linkage project, we really look forward to working with our IT staff and other colleagues to implement the phase 3 linkage very soon. As a matter of fact, it would most likely be sometime next month. Once we have the linked data and the validated data files, we very much look forward to exploring and producing more analyses on our healthcare system. You know, in the newly linked data, we will have more accurate peer information, more accurate patient eligibility or enrollment information, including dual eligibility status, and much better payment amounts for various types of services. As you may know, there are a lot of limitations in the charge amounts from case mix data. So from there, we hope to improve and refine our current reporting, such as our annual reporting on unplanned hospital readmissions and the revisits. We are also looking forward to opportunities to explore and produce additional and hopefully better analyses and reporting on health system performance, healthcare cost, and trends. Thank you again for having us. Kat, you also survived with the internet challenges. So we're more than happy to entertain any questions that you may have.
Thank you, Z, and thank you, Kat. Just being mindful of the time, I want to make sure that we have enough time to get to our final presenter, and hopefully we'll have just a minute or two for questions at the end. They've been really interesting presentations, so we'll do our best. So with that, we have Marianne Evans, who's going to talk to us about linking the Oregon APCD with other sources of race and ethnicity data. Marianne?
Welcome. Second, let me get this up. Take just a second. All right, can everyone see and hear me?
Yes.
All right, great. Thank you. Welcome. I'm Marianne Evans, and I'm an analyst from the Oregon Health Authority. And my presentation today is about the Oregon All Payers All Claims data and leveraging race and ethnicity data from other data sources. I want to acknowledge the collaboration of lots of folks in our agency and across other parts of Oregon that have helped with this. I want to especially acknowledge the Office of Equity and Inclusion and the Department of Human Services. So just to give you a little background about APAC, we have data from 2010 to current. We have up to 98% of the Oregon population represented in APAC. It has commercial, Medicaid, and Medicare data. We have inpatient, outpatient, professional, and pharmacy claims. We have monthly enrollment data. So that means we have coverage for folks who have enrollment data for people who may have no claims. We also have billed premium data and extensive provider data. You'll see at the bottom of this website a link. You can go out there and you can see a lot more information about the Oregon APAC data and how to request it if you're interested. So just to give you sort of a bird's eye view of the data, we have about 3.8 to 4.2 million people in the Oregon population. And you can see from this slide, the amount of people in APAC ranged from 3.4 to 3.9 million. About 1% of the people in APAC are not Oregon residents. So we have up to 98% of Oregon residents in APAC. From this slide, I wanted to share a little bit about the type of coverage people have. So you can see here that about 53% of the people are covered by commercial insurance, about a third are covered by Medicaid, and about 25% are covered by Medicare. So if you add those up, you can see it's more than 100%. That's because people have multiple coverage at the same time or during the same year. So 15% of commercial, people insured by commercial insurance have other coverage, 20% of Medicaid, and 24% of Medicare. So about my presentation, really we have a paucity of race and ethnicity data in APAC. 59% of the people in APAC we don't have any race data for, and 72% of the people we have no ethnicity data for. And that's what really triggered this project. The objective was really to strengthen the availability of race and ethnicity data in APAC. And the idea was to leverage race and ethnicity data from other state data sources. Ultimately, the goal is to inform efforts to reduce health inequities, which is an Oregon Health Authority priority. So the other state data sources we leveraged were the Oregon Eligibility, which we refer to as ONE, and the Oregon Integrated Client Services Warehouse. The ONE system is our application system, and people self-report race and ethnicity data along with language and disability data. The Integrated Client Service Warehouse collects data on a monthly, quarterly, or annual basis from a wide variety of Oregon Health Authority, Department of Human Services, and other state programs. So some of the large ones are temporary assistance for needy families, food stamps, WIC, Medicaid, Housing and Community Services, from the Employment Department, from the Education Department, and from the Corrections Department. Not all of the data sources in ICS report race and ethnicity. So the method we use today, we've done a lot of different work with race and ethnicity with this leverage data, but the one I'm going to share today is what we refer to as the preferred or rarest race and ethnicity method. I want to mention that this is a pilot project. We can talk more about that later. But this preferred rarest race methodology identifies a single race ethnicity based on what the person selects as their preferred, and if they don't select a preferred, on the rarest race or ethnicity reported. In this case, we prioritize the self-identified preferred race from the ONE data. That's the only data source we have that is that we are confident is self-identified. The rarest race and ethnicity is based on race and ethnicity distribution in the state. So in Oregon, Native Hawaiian Pacific Islander is the rarest race ethnicity, Black or African American second, American Indian or Alaskan Native, Hispanic, Latino, Asian, or white. Other is not the most common. It's just what, if you report a different race, it ends up there. Again, we prioritized our data sources. We have, again, as I mentioned, one is our RealD compliant data source. It's self-reported, and it actually identifies their preferred race and ethnicity. So anyone who has one data, that's the data that is leveraged and used. If they don't have one data, then we look at APAC and ICS and pick out the rarest race ethnicity reported. At the bottom of this slide, you'll see, again, another link, and that sends you to a site that you can learn more about the preferred rarest race methodology. So in APAC, at this time in 2018, we had cumulatively about 6 million people in APAC. We matched APAC 1 and ICS by names and dates of birth. We used both probabilistic and deterministic matching methods and software. When we leveraged, race and ethnicity was identified for 97% of the people with Medicaid, 96% of the people with Medicare, and 67% of the people with commercial. So you can see the marginal gain we achieved in leveraging race and ethnicity from the other data sources. So here's a nice summary chart. And again, this is over from 2010 to current, up through 2018, the race and ethnic preferred rarest race ethnic distribution of people in APAC. So I draw your attention to the far right where it says no race and ethnicity. That indicates that in none of the data sources did we have a race or ethnicity reported. It's about 1.5 million people, about 26%. 95% of those are from commercial insurers. That's because while insurers are mandatorily required to report to APAC, if they don't collect race and ethnicity data from the employer or in their health plan, then they don't have the data to report. Then I want to turn your attention to each of the race ethnic groups to sort of give you a sense over time what's gone on with them and what the type of coverage. So we'll start with the rarest race ethnicity, which is Hawaiian Pacific Islander, which is 0.5%. There are about 18,000 in 2018, and you can see across time what that varied. About 67% of Hawaiian Pacific Islanders are covered by Medicaid, 39% by commercial, and 7% by Medicare. And you can see quickly from this chart the impact of the ACA, and you see that in 2015, the expansion of Medicaid. The next rarest group is Black or African, people who identify or report as Black or African American. You have about 127,000 in 2018. About half are covered by have Medicaid coverage, about 37% commercial coverage, and about 29% Medicare. And again, you can see the impact of the ACA in 2015 and the expansion of Medicaid. The next group is American Indian or Alaska Native. They make up about 2% of APAC. You have about 83,000 in 2018. About 70% were covered by Medicaid, 27% commercial insurance, and 14% Medicare. And again, I'll point out in 2015, the impact of the ACA, the expansion of the larger percent covered by Medicaid. Hispanic Latino, self-report identify as Hispanic. About 9% of the people in APAC identify as Hispanic Latino. It's about a little over 360,000 people. About 67% are covered by Medicaid, about 36% by commercial, and 7% by Medicare. And again, you can see the impact of the ACA in 2015. About 3% of the members in APAC report as Asian, about 203,000 in 2018. About 51% were covered by commercial insurance, 44% by Medicaid, and 19% by Medicare. And again, you see the impact of the ACA in 2015. About 55% of the members in APAC report white. Again, it's about 2.7 million people in 2018. About 45% report have coverage, commercial coverage. About 35% Medicaid coverage, and about 35% Medicare coverage. And again, you see the impact of the ACA in 2015. There's a lot of issues and a lot of discussion about the leveraged race and ethnicity data. It's an ongoing effort. I want to emphasize that this is a pilot project. We're talking about some of the limitations of the data, whether the data is valid and reliable, how much confidence we have in the data, the sensitive nature of the data, the opportunities this data offers, community stakeholder and input, and how we would go about sharing this data. Oops, somehow I lost my, I wanted to provide some contact information for those of you who are interested. Again, the top one is our APAC website. You can go out there. I find that the data request page, if you look on the data requesters page, you'll see an APAC data dictionary, a data user guide, and a lot of helpful information about requesting data. I also want to point your attention to our RealD websites. That gives you our race, ethnicity, and language and disability data form that folks fill out for the one and other programs, and our health and equity office. Again, my name is Marianne Evans. My contact information is there, and feel free to email or call me.
Thank you so much, Marianne. We do have a question coming in, and we have about 5 minutes or 4 minutes now. So if folks have questions, please submit them. But one of the questions here is, are the race ethnicity categories the same across APAC, the Oregon Hospital Discharge Database, the US Census, or insurance enrollment data? And if not, what needs to be done, or what did you do to harmonize them?
From all of the different data sources, you get from the payer data from APAC. What we get is we have 60+ different payers, and they report data. It's unknown to us how they collect the data. We require them to put it into a certain format, but the origins are unknown. Medicaid collects the data in a RealD format, but that data is not conveyed in RealD to APAC. Again, the one system, that's our eligibility system, is the only data source we have that is RealD compliant, that collects it using the form and has that data available, and it identifies the preferred race and ethnicity and all the disaggregated data for race and ethnicity. So what I've shared with you today is an aggregation. So the one data gives that data disaggregated as well.
Thank you. This is a question for all the panelists. For those that described collecting data from different sources and integrating the data, were there any challenges that you experienced in getting the data or pushback from other agencies or stakeholders in your interest in integrating it? Marianne, you're laughing.
Oh, not so much pushback. I think everyone, you know, and again, I don't speak on behalf, but this effort took years to come to fruition. And again, we're still in a pilot phase. But again, I think people are very interested in recognize that not having adequate any race or race and ethnicity data, or very little or very poor quality, does not support policy and research to looking at potential inequities or disparities. And so this pilot presents an opportunity where you have race and ethnicity data for most of the people in Medicaid and most of the people in Medicare, and almost 70% of the people in commercial insurance. We have additional pieces and updates that we think we can improve that. So it's not that anybody is a barrier. I think because the topic is very sensitive, and I think because the methodology is not necessarily everyone understands it or agrees upon it. I think there's a lot of work around getting consensus or getting support for the data.
Thank you. Anyone else have a comment on difficulty in collecting or integrating? A short comment?
I mean, our big thing in our world is data flows at the speed of trust. So just like Marianne said, you know, it's all about relationships and discussion and having really tough conversations. And I just think you have to start there.
Thank you, Amy. Well, we are at time. I want to thank all of our panelists for their presentations. I found it really interesting, and hopefully everyone did as well. I think it's germane to a lot of the work that's happening nationwide. So thank you again, everyone, and happy Wednesday afternoon.
Thank you, Tanya.
Much.
Thanks.
Have a good
Thanks, everybody.
Bye,
Thank
everyone.
you. Bye-bye.